Uh, I think we are live.
Hello, good evening, everyone. Good evening, everyone. A very warm welcome to this insightful panel discussion on the discussion on ovarian cancers, what a gynecologist must know. It is organized by IGCP Group. I am Ada from IGCP, and it is a truly privilege to have such an eminent panel of experts joining us today for this important academic discussion in the field of gynecology and oncology. So today's discussion is scheduled on 8th May from 7 p.m. to 8 p.m. and we are looking forward to an engaging and enriching exchange of knowledge. So it is now my honor to introduce our esteemed chairperson for this evening. First, we warmly welcome Dr. Sharda Jain ma'am. She is a highly respected name in women's health care. She is the senior consultant in the Department of Obstetrics and Gynecology, Director of Life Care Center and Life Care IVF, member of the Expert Ethical Committee at NMC, Secretary General of DGF, and the founder and the chairman of NIGF. So, our second esteemed chairperson is Dr. Mala Srivastava ma'am. She is the director of Gynae Oncology. She is the professor at GRIPMER and the renowned gynae endoscopic and the robotic surgeon at SIR Gangaram Hospital in New Delhi. She also serves as the chairperson of the Clinical Research Committee of FOGSI and president of NARCHI Delhi chapter for 24 to 26. Her dedication towards advancing gynecology, oncology, and women's health research is truly commendable. Ma'am, we are delighted to welcome you, ma'am. Now I'd like to introduce our moderator for this evening. We are privileged to have Dr. Vaishali Paliwal ma'am with us today. She completed her MBBS and MS in obstetrics and gynecology, followed by an MCH gynecological oncology. She has also completed a fellowship in minimal access surgery and is an MRCOG from the UK with certification. Her expertise in gynecology, oncology, and minimally invasive surgery has made her a highly respected clinician and academician in the field. Joining another moderator for today, Dr. Monisha Gupta, ma'am. She is the Associate Director, Gynecology, Oncology, and Expert Robotic Laparoscopic Gynae, Oncosurgeon at Max Super Specialty. Her extensive experience in advanced gynecological oncology procedures and the patient care has earned her immense recognition in the medical fraternity. We are equally honored to have exceptional panel of experts with us today, ma'am. Thank you for all taking out your valuable time to be a part of this academic session. Now I'm handling the session to you, ma'am. Thank you.
So thank you, Ada, for the introduction. And I would like to introduce our esteemed panelists for today. So today, joining us would be Dr. Neha Kumar. She is a senior consultant, Gynae Oncology, Amrita Institute of Medical Sciences, Faridabad. Then the next gynae oncologist that we have is Dr. Renuka Gupta. She's a senior consultant, Gynae Oncology in Rajiv Gandhi Institute of Cancer. Then we have Dr. Swasti. She is the Senior Director, Gynae Cancer Surgeon, Max Vaishali and Max Noida. Then we have Dr. Shruti Bhatia. She is the Director, Gynae Oncology from BLK Max Super Speciality Hospital. Apart from that, joining us is a very senior medical oncologist, Dr. Ankur Behel. He is the Principal Director, Medical Oncology in Fortis, Gurgaon. Then in a pathology, we have Dr. Komal Agrawal. She's a senior consultant in the pathology department of Fortis, Gurgaon. Apart from that, we have Dr. Lakshay Gupta. He is a senior consultant in radiation oncology, Fortis, Gurgaon. And last but not the least, Dr. Neha Kakkar. He is a consultant radiation oncology in Fortis, Gurgaon. So we have total art panelists. And before the
Dr. Vaishali, you are not audible. Yeah. Hello?
I have just invited before Dr. Monica to start. Am I audible now?
Yeah, you're audible now.
Yes, you are audible.
Case, but just Dr. Mala, I would, if you would like to say a few words.
No, it's a good opportunity for all of us to discuss some cases on panel discussion on ovarian cancer. And I think Dr. Vaishali will do a good job. Dr. Vaishali and Dr. Manisha, they are having good collection of cases. And I'm sure we'll have a good interactive and informative session in panel discussion. And you have an elite panelists. I can see they are all very senior persons in their own field and domain. And we are looking forward to this panel discussion.
Thank you so much, ma'am, for joining us. So, Dr. Monisha, let's start with the first case.
Yeah, thanks, Dr. Vaishali. Ada, I'm just sharing my slides.
Sure, ma'am.
Just let me know if it's visible and it's visible. My screen is visible.
Yes, ma'am. Your screen is visible, ma'am.
And the slides now?
Yes, ma'am. And keep it in a full view. Okay, perfect.
Oh, fine. Scrolling down. So, a very good evening to all, and thanks, Dr. Mala ma'am, Dr. Shada ma'am, to take this initiative on the occasion of Ovarian Cancer Day. And ovarian cancer is a huge subject, and it's a full subject in itself, and we can discuss it as much as we can. So, I request to all my panelists to keep it as concise and precise so that we can discuss. We need to discuss just two cases, but interesting ones, and we can discuss in full, and we can still complete on time. So with that, we have already introduced our panelist. So just introduction that whenever as a gynecologist or a cancer specialist, we get any ovarian mass in our OPD, our main school of thought goes in the lines that to know the probable etiology of the mass, maybe like benign or malignant, as far as possible. If benign, so whether we can go for a conservative management or we should go for a surgical approach. And if for surgical approach or for malignant cases, whether we can go for laparoscopy or laparotomy would have been better for her. So with these cool thoughts in mind, we evaluate any ovarian mass in our OPD. And on that lines, I would like to discuss my first case. My first case is in a 32-year-old Paris woman, Para-1 live one, who has delivered normally just 2.5 years back. And she presented to me with a dull, aching lower abdominal pain for the past 4 months. And she resumed her normal menses after delivery, after about 10 months of delivery. And till now, they are normal and regular and with no family history of any cancer. And she came to me with a TVS showing a large, solid cystic lobulated 11 into 11 into 15 centimeter mass in the right adnexa in the adjoining POD with no ovaries being seen separately from the lesion. So with that, my first question goes to Dr. Swasti, that can you quickly enumerate the points which you will look for in the clinical examination? Dr. Swasti.
Yeah. So, our examination must begin with the assessment of a comprehensive nodal sites. Breast examination is not to be missed. Am I audible?
You're audible.
Yeah. So, breast examination is not to be missed. We have to examine both the breast and the axilla. And we have to do an abdominal speculum and a vaginal examination. That's important. Also, look for the inguinal sites. Any pallor edema as a part of our routine general physical examination must be done. So, it's important, and especially if this lady was not married, suppose we get younger girls, then of course a rectal examination is very, very important if we cannot do a bimanual vaginal examination.
Okay. So anything Dr. Neha would like to add on that? Dr. Neha, are you there? Am I audible?
Yeah, Dr. Monisha, sorry, I have a bad connection.
Yes, so I would like to take into account the history of the patient, how long the patient has been having the symptoms, and like Dr. Swasti enumerated, a complete systemic examination and a local examination. When I'm doing the pelvic examination, I have to see whether the mass is cystic or it is firm to hard, whether it is irregular or the contours are smooth, whether it is mobile or not. Can I feel any ascites or not? Can I feel the mass separate from the uterus? Do I feel any nodularity in the pouch of Douglas? Is there any disease involving the rectal mucosa? All this can be assessed on a complete PVR examination. We also need to see whether there is any tenderness or not, and we need to keep our differentials in mind, considering both the history as well as the physical examination, trying to keep the DDs of endometriomas, pelvic inflammatory disease, and also ruling out other adnexal masses which can appear in this region like rectal masses, appendicular masses. All those should also be in our differential, especially in a young woman.
Yeah. So rightly said, Dr. Swasti and Dr. Neha, with actually a presumed report of a solid cystic mass on TVS, sometimes your mind goes like on the lines of malignancy only. So rightly pointed by Dr. Neha that we should not forget the benign pathologies, tubular masses, the endometriomas, which can have a solid lesions, and we should examine the patient on those lines also. So, on examination in this patient, it was a firm mass which is fixed in the POD with the irregular borders. There was no free fluid in the pelvis. Cervix was normal. Uterus was retroverted but slightly appeared bulky. And there was a slight nodularity in the POD, but it was more like an irregular contour of the mass. But the rectal mucosa, the overlying mucosa, was free. So, my next question to Dr. Renuka, that how will you go further in this case? Dr. Renuka?
So basically, whenever I'll feel this kind of masses, generally I have to rule out that this is a malignant or also some. I would like to do the tumor markers, basically CA 125, CA 19.9. I usually do, and as she is a very young woman, I would like to do the germ cell tumor markers also. So basically CEA, that alpha fetoprotein, beta CG, and usually LDH I'll do. Inhibin B only I'll do only the patient if she had a bleeding tendencies or change in the bleeding pattern or irregular heavy bleedings are there. And usually if I'm having only the TVS, definitely I'll go for the good MRI with contrast for this patient.
So, just out of the box question to all my gynae oncology colleagues, that how often in your clinical practice, despite in the guidelines, are all of you doing HE4 in the routine evaluation of an Excel masses? It's an open
So,
question, like anybody.
I don't think so. We are doing very
No,
commonly. Yeah.
I'm not doing
Dr.
usually
Swasti is
HE4
not doing.
basically.
no,
Dr.
not doing.
No,
Yeah.
I'm not also. I'm also not doing.
Dr. Vaishali not doing. Dr. Renuka
Not doing.
not doing.
Not doing.
Dr. Shruti.
No, only in certain cases where there is a lot of confusion and patient wants a conservative approach, then only. Otherwise, not routinely.
So it's a routine question to all of us from our gynae colleagues that HE4 करना है, HE4 करना है, but practically for the oncology practice, it is not making any practical difference despite being in all the guidelines and recommendations. So that is I want to point out to all the gynae audience that HE4 is there in the guidelines, but practically it's not making much difference in your decision making for the management in the patients. So coming back to this patient, she has all the markers were done. CA 125 was 78, marginally raised. CA 19.9 was marginally raised, and all the other germ cell markers were normal. So, Dr. Shruti, how often are you advocating doing RMI in the routine clinical practice, sitting in the OPT, the mass?
Yeah, so just like HE4, I think as an oncologist, for me, RMI is more like a theoretical thing than actually a practical approach.
Okay.
And but still, it is for our general gynecologists, it is good to know because at least they can assess if the mass is going towards benign or a malignant mass. Because the main role of RMI is for a gynecologist to assess the mass which I'm planning to operate is a benign or a malignant mass. So RMI basically includes three parameters: the menopausal status, if the patient is menopausal or not, that gives a points 1 or 3. Then the CA 125 levels and ultrasound findings, which includes the type of the nature, the cyst, the solid areas in the cyst, presence of metastasis, bilateral or ascites in the ultrasound findings. So all these three parameters are multiplied. Like the ultrasound scoring is given, you give points 0, 1, and 3, and menopausal status is 1 or 3, and CA125 is the absolute value. If the RMI score is more than 200, or certain articles say more than 250, then the mass is probably malignant, and that is the mass I think the general gynecologist should refer the patient to a gynae oncologist. But for a mass which is RMI less than 25, where the mass is probably benign, we can do a treatment without oncology approach.
So in the nutshell, is it right to say that it is more of a convenient biomarkers to be done sitting in the OPD, and it is basically to decide that when you need to refer a case to a gynae oncologist?
I agree with you. Yes. So basically, as I said, I think the theme of today's was ki how we should evaluate and manage our ovarian masses. So there again, for a person who is in doubt if the patient should be referred and how to approach, this is a modality.
So any difference of opinion from anybody, any other view from any other person, from any other gynae oncologist?
So I
Dr.
think
Reddy?
just one more thing, Dr. Monisha, I'd like to say that a normal CA 125 doesn't rule out a malignancy, and an abnormal CA 125 also doesn't prove a malignancy. So based on that, especially for premenopausal women, more than relying on CA 125, where RMIs were actually introduced only mostly for postmenopausal women, because there the sensitivity of CA 125 rises quite a bit. So I think for the gynae colleagues, the main bit is that CA125 normal should not be thought of as non-malignant, and a rise in CA125 is not always cancer.
So the accuracy of RMI index is also doubtful, and a lot of subjectivity and loopholes are there. So on that note,
Monisha, I'll just add here actually the radiology is the most important and one of the most essential tools. So whenever we are in doubt, ultrasound or as Renuka suggested, MRI. So best is a good dialogue with your radiologist will actually tell you most. There we don't need RMI or any such thing. So that is the best modality, what I believe.
But yes, like for the remote, not for the remote areas, but for the general nursing home practice or the OPD practices, I think it is more of a convenient marker. Not very accurate, but still something is there with the gynecologist to decide whether they should keep the case or they should refer the case, something like that. So on that note, we come to a more objective non-CA 125 dependent biomarker panel, if there is any. Dr. Lakshay can throw a light on that. Dr. Lakshay.
So, given any ovarian mass, my first investigation would be an ultrasound. Okay. Of course, and the most valuable thing in ultrasound is that if we rule out that the lesion is absolutely benign, we can decrease the anxiety of the patient, and we can just follow it right from there. But if I see any marker on ultrasound, like a solid nodule within the lesion or any thick septae which are more than 2 or 3 mm, I would immediately do an MRI, not to miss out on any low grade or any malignancy that might be behaving like a benign pathology. So on ultrasound, we generally rely on unilocularity. If the cyst is less than 10 centimeter, the septae are less than 2 mm, and if there are no other solid areas, no vascularity within the lesion, then we classify that as absolutely benign, and we can just stop our search there for malignancy. But if I find anything which is concerning, so any color Doppler flow or any solid areas, especially if there are more than 4, so I would immediately suggest an MRI. CT has no role in primary diagnosis, at least.
Yeah.
And so, also, PET CT would come at a later stage when we are sure that we will discuss
later. Yeah. So all of the features which you've enumerated, Dr. Lakshay, can like right now, what is like IOTA classification, just like Viraj's classification for breast lumps. IOTA classification has come up like a more objective tool to evaluate the ovarian masses. So how often are you doing that, and how And just tell about the accuracy of iota classification, because it's a non CA 125 dependent panel. So ruling out a lot of subjectivity and lot of low sensitivity and specificity of CA 125. So how accurate is this, and how it can change the clinical practice of gynecologist?
Yes. So, Dr. Manisha, the current thing that we use is ORADS instead of iota classification. And
Okay.
ORADS is both for MRI and for ultrasounds.
Both, yeah. So tell us about that a little bit. Okay.
On ORADS objective, and we have more particular lesion. In ORADS 1, we just mentioned normal findings. ORADS 2 is definitely benign findings. ORADS 3 is generally less than 5% chances of malignancy, which are to be followed. ORADS 4 and 5 in both ultrasound and MRI are lesions which are concerning for malignancy with at least 50% chances of malignancy.
So you would advocate like ORADS on ultrasound, because sometimes the gynecologists, they don't go for MRIs, or maybe they are more comfortable with ultrasound.
Yes, so we have ORADS in ultrasound, like
in ultrasound for them.
Yeah. Yes, we have ORADS in ultrasound.
So that is a more objective biomarker panel for
the advantage over iota is that we have more classification, more categories to classify a particular lesion.
Okay.
So it gives us and the gynae oncologists more leverage, and we can advise the patient better whether to follow up or go for an immediate MRI or
ORADS 3 and 4, like in VIRAT 3 and 4. In ORADS 3 and 4, basically you have to go for a MRI or PET, depending upon
4 and 5. Yes.
Yeah. Further investigation is required. Must. Yeah. So coming back to this patient, she had been advised CACT scan somehow, and it came out to be a large, well-defined, multiloculated solid cystic mass in bilateral anorexia. It is like about 10 into 9 into 16 centimeter on one side on the left, and 11 into 8 centimeter on the other side. And it was a solid cystic mass with a mild hydronephrosis with dilatation of proximal ureter on one side, right side. And it was a bilateral mass with subcentrometric mesenteric lymphadenopathy on CT scan. No free fluid in the abdominal cavity, peritoneal cavity. So now coming back to Dr. Swasti, would you go for a PET CT for her, or I would rather ask, do you go for a PET CT for every solid cystic masses on ovarian masses on CT scan? What is your
depending on what you find on a CT, I think it's important to assess. In this patient, she's got bilateral masses. There is some amount of lymphadenopathy, mild ascites. So I think it's important that we look for extra abdominal disease as well. CT sort of indicates a possibility of malignancy here. So a PET CT would be beneficial. By far, as in practice, bilateral masses, I always prefer to do a PET CT.
So, Dr. Lakshay, would you agree with Dr. Swasti that this patient should go for PET CT? It will go ahead.
I would disagree. Unless we're sure that we're dealing with malignancy, the next investigation should be an MR instead of CT. So even if the patient has got a CT done, I would still go for an MR, find out whether I see any signs of malignancy within the lesion. And then if only staging is required, I would go for it. Otherwise, no. And given ovarian malignancies do spread in the abdomen along the peritoneum, so peritoneal imaging, MRI is by far the best investigation. So PET may or may not pick up peritoneal disease.
Okay.
If we consider
very readily picked up.
Excuse me. If you consider this patient, CECT is good enough just to assess the disease. There is no need of PET CT, I think, because there is no extra abdominal disease. But there is no disease exactly. It's a bilateral masses only. No peritoneal disease is there. So I don't think PET CT is having a higher sensitivity than CECT in this case.
Of course.
Okay, so we have three different opinions. One want to go for PET CT, another want to go for another MRI, and the third wants CT is enough. We don't want to go for PET, and we don't want to go for MRI. So, what should be the further way, Dr. Shruti? What will you do in this case?
Hello,
Dr. Shruti.
Yeah.
Bilateral ovarian solid cystic masses on CT scan with a mild lymphadenopathy. Would you go for PET-CT? Would you go for MRI or nothing?
I think PET-CT is not mandatory to be
Okay.
done, but there is because again, as in a practice, we understand a lot of it is demand by the patient. कि डॉक्टर साहब पेट नहीं कराया, so that is the only indication of doing PET. Otherwise, a CT.
That's a practical indication.
Yeah,
So,
that is the only indication. Otherwise, there is no indication.
According to you, there is no clinical indication.
No, and unless or if you are doing, we can do a CT chest if required. If
Yeah.
you are suspecting any extra abdominal disease and a PET-CT per se. But yes, although in this case her CE and rest of the markers were normal, if there was some increase in those markers, then we may think of PET-CT. Otherwise, I don't think we need in this case.
But I think,
Anisha, can I chip in for a second?
sir,
30
I want
seconds.
you to chip in, but I will take your name just 1 minute. So, Dr. Shruti, if I conclude your comment, you want to exclude extra abdominal disease in this case, but not with PET-CT, with the CT chest.
Yeah.
Am I right?
That will
Yeah.
be good. Yeah.
Okay. So now, Dr. Ankur, it's your turn to chip in.
So I need a very good endoscopy, upper GI endoscopy with a retroflexed. I want to
Now
see
we
the
are
gastric.
discussing PET-CT. We will discuss endoscopy, but right now we are discussing PET.
So PET scan might not be a good thing for. It's not a option without endoscopy and colonoscopy, but yes, at times we see gastric tumors growing to a gastric Krukenberg. We have to see a cecal or a ileocecal mass going as a Krukenberg. We have to seriously see an appendix going as a Krukenberg. My differential diagnosis for this patient who is a 32-year-old is a granulosa, Sertoli, germ cell tumor, or a Krukenberg coming from extraovarian, and a very good per-rectal examination to see any ascites in the cul-de-sac. So a comprehensive investigation from oncological perspective, which might not include a PET scan, but at times we have seen on a FAPI scan as well, a mucinous carcinoma of the stomach or an appendiceal tumor of the mucinous appendiceal tumor giving rise to these Krukenberg, especially in young female, if the marker are normal. And also do not, I would suggest still, it might be an old practice, but a CA to CA 125 ratio is very important in such
It's
cases.
still very important. It's conventional, but still it holds its importance. And
Yes.
sometimes we do it regularly in our OPDs. And so, one word, sir, Dr. Ankur, if this patient comes to your OPD with CT and ultrasound, will you go for PET-CT, yes or no?
Yes, I would.
You will.
I would, because operating this patient and getting a frozen section before putting a knife on it, I have to be very comprehensive, and PET-CT scan is not a big deal in the city.
And sometimes, as you pointed out, that gastric carcinomas might be a cause of like this.
Gastric carcinomas of mucosal disease going to a
Mucosal disease, which may
transalumic,
not be evident on endoscopy.
transalumic spread to the Krukenberg, even
Yeah.
without a para-aortic lymph node, even without a transalumic ascites, we have seen lots of patients.
We have seen that.
So this in 2026, it's better to rule out rather than be overconfident with a clinical or a radiological clinical or a old book practice.
So clinical indications, as you pointed out, to rule out the secondaries from other organs.
Krukenberg, bilateral solid cystic with just a rise of CA125 or a normal CA125 with normal germ cell tumor markers, beta HCG, alpha fetoprotein, and LDH, even inhibin A or B. Just
all
rule out.
In this case. All are
just
we have
rule
not
out a good PET-CT scan and upper G and a colonoscopy.
So medically also, I think PET-CT should be done even if there is a little clinical indication, because nowadays it's a time that, as Dr. Shruti has pointed out, कि patient ही आके बोलता है कि PET क्यों नहीं कराया. So medico-legally angle is also there, and
1 in 200 or 1 in 300 we might miss, all of us.
Yeah. So Dr. Neha, your comment on requirement of PET-CT in this case, will you go for it, yes or no?
So I think endoscopy, definitely. Upper GI endoscopy, colonoscopy, no doubt about it. How much? See, a good CT scan versus
a good CECT, thorax, abdomen, and pelvis versus a good PET scan when you are already doing an endoscopy in this case. And in this case, I would go for an endoscopy because there are bilateral adnexal masses. CA 19.9 is raised, CA 125 is not that raised, CA 125 by CE ratio is less than 25. So if you are already doing an endoscopy and if the CECT, thorax, abdomen, and pelvis is done and read by a good experienced radiologist, I'm not sure how much uh, a PET CT would add to that if we are going for an endoscopy and if we have a well-read CECT, thorax, abdomen, and pelvis.
To take it. So in this case, we did go for PET CT and it came out to be a metabolically active solid cystic mass in the lower abdomen bilateral. It is like 14 centimeter on one side, 9 centimeter on another side with mildly metabolically active abdominal pelvic lymph nodes with iotocaval, precaval, and bilateral commonalic nodes, minimal ascites, and no other metastatic disease. So as already discussed with Dr. Neha, would you like to go for upper and lower GScopy? Yes, she would like to go for it. Yeah. So apart from Dr. Neha, bilateral ovarian masses and the raised CA 19.9, as you have pointed out, what are the other indications in your practice where you go for the GScopy or ovarian
Yes. Yes. So a patient who presents with GI symptoms like sudden loss of appetite, difficulty eating, change in bowel habits, markedly elevated CA 19.9, like I said, raised CA 125 by CE ratio. All these are indicators where there are bilateral adnexal masses. Appendicular masses cannot be ruled out on colonoscopy. Many times colonoscopy can not pick up appendicular masses, but at the same time, whenever a marker is raised, we are having pseudomyxoma peritoneal-like picture. I would definitely like to rule out any primary in the upper GI or the lower GI tract.
So, any other point from anybody else? Dr. Ankur, Dr. Renuka, Dr.
So very remotely, a tuberculosis, or where I mean, it can be still in country. We have to see although there are no symptoms, weight loss, fever, and all. But yes, it is one of the differential diagnosis. And very rarely we have got some very fancy diagnosis of small cell or a lymphoma as well. But yes, tuberculosis also should be one of the differential diagnoses.
So coming back to the patient, its upper and lower GScopy were done and they were normal. So just to summarize the case, it was a 32-year Paris female with bilateral ovarian solid cystic masses with mild ascites and mild lymphadenopathy on PET CT, normal upper and lower GScopy and marginally raised CA 125 and CA 19.9 and normal germ cell markers. So we proceed with the management, Dr. Shruti, Dr. Renuka. So for Dr. Shruti, my question is role of biopsy in this case. And if no, if you would like to go for surgery, then the laparoscopy or laparotomy. Dr. Shruti.
I would not do a biopsy in this case because you have already done a PET and PET shows probably it's a mitotic mass.
Yeah.
So it's a bilateral masses. We have to do a good counseling with the patient, which is most important because she's a young lady with bilateral masses which are suspicious. So doing a biopsy will not add much to our knowledge because it is not that metastatic disease where we know that we cannot operate and we have to go for a new adjuvant chemotherapy. The only indication of doing a biopsy in adnexal masses in a metastatic disease where primary surgery is not possible and we want to do a new adjuvant chemotherapy. Otherwise, in this case, biopsy has no role. It just upstage the disease.
Yes.
And secondly, regarding laparoscopy or laparotomy, I'll go for laparotomy and frozen section and proceed for both the masses. Prior to that, good counseling because she's just para 1, explaining her about her fertility compromise if bilateral masses are malignant.
So with that, my question comes to Dr. Renuka, ki although she is a Paris lady, but she is a 2.5-year-old baby. So if there is a fertility concern, so any role of fertility preservation in this case?
So basically, if we'll see this patient says her CA 125 is not very much raised, CA 19.9 is, I would like to go for the diagnostic lab first just to rule out if there is any undue disease. Basically, maybe sometimes small bowel disease, peritoneal deposits are there, which we can miss over the PET also. So diagnostic lab and proceed, I would like to do. I won't proceed with laparoscopy. I would definitely do laparotomy for this patient. Yes, definitely I'll do cystectomy first because fertility preservation can do in the patient if she is having a borderline tumor or the mucinous tumors. So I'd like to go for the cystectomy and frozen definitely. And if the frozen says it is in a borderline tumor, and if patient wishes to preserve her ovaries, definitely I'll give trial for this with complete staging for this.
Dr. Neha, your opinion on the management?
Yeah, so Dr. Monisha, I would differ just slightly. There were two masses. I would like to remove the complete mass, which was the bigger size, the 16 centimeter mass. I
Yeah.
would like to remove it completely.
Yeah.
I would actually tell the relatives that, with regards to preservation of the other ovary, she has one child, so she should be given an informed consent beforehand that
Yeah.
chances of recurrence are 25% with just a cystectomy versus less than 5% with a unilateral adnexectomy. So, with regards to the bigger mass, I would remove completely. If she
But
still
still,
wants the fertility preservation,
Dr. Neha, sorry to interrupt, but still you don't know the histology. So,
yeah, yeah.
so on what basis will we consult the patients about the rate of recurrence?
Yeah, so I think before we go ahead, so she has two masses. We have to decide beforehand that
Yes.
one mass which is already 16 centimeter in size. There is very little possibility that you will find any normal ovarian tissue left. So I think it is important to remove the bigger mass first, send it for frozen section.
Yeah.
That frozen section will be positive, borderline, or benign. It
Yeah.
is likely to be borderline or malignant based on your findings.
Yeah.
If it is borderline, then yes, the other ovary, if normal tissue is left, you can think of leaving behind, provided she is accepting that risk of recurrence. But on the other hand, if she does not want that risk of recurrence, you should remove the other ovary. One thing which can be done in with respect to fertility preservation, only if the uterus is grossly normal, is leave the uterus behind.
So bingo.
So definitely counseling is important, but all depends on the frozen of the reports na, and patient wishes. Basically,
Yeah.
if the disease is borderline only, definitely we can save.
Totally agree. Totally agree, Dr. Renuka. The role of pathologist is very important.
Yeah, role of pathologist is very important in this.
Very important. So,
We can have, I'll just add, we have two masses, so we can have two different pathologies as well.
yeah.
Definitely, both
Both the
masses
masses, it
for
have to
the
be
woman.
counseled.
Yes.
So,
Dr. Shruti, please let not complicate the case of further
Okay.
for all practical purpose. So, one, Dr. Renuka wants to go for diagnostic laparoscopy followed by her finding, and Dr. Neha wants to go for laparotomy, removal of one mass, frozen section, and proceed. So, Dr. Shruti, what will you do?
I agree with Neha. We have to good counseling regarding her fertility, and although she is just para one, but we have to tell her she has one child.
Yeah.
So patient is the first priority. And as Neha said, ki the chances of recurrence are much more if we just do remove a cyst. On the contrary, if we remove the entire adnexa, the chances of recurrence will be definitely less. So we have to explain to the patient for all the three scenarios. If it's a benign, what could be the chances? If it's a borderline or it's a malignant. So good counseling is very important. Secondly, again, I would go for a laparotomy. Frozen, remove the entire bigger mass, send it for frozen. For the second, depends on the counseling. If the patient is thinks that fertility is not that important, then for second mass also I will remove the entire thing and then send it for frozen. But if we can preserve a part of a normal ovary in a second mass, we can attempt.
Okay. So,
there is also a chance of second surgery. No, it's a counseling is important.
Dr. Renuka, hold. Actually, we need to proceed also. So, one comment from Dr. Swasti that whatever Dr. Neha, Dr. Renuka, and Dr. Shruti has said, it needs a lot of counseling. Just in one line, you need to tell ki this kind of counseling would you like to do in the OPD or after in the OT itself after your frozen report?
Every counseling or every possibility should be explained to the patient and her family, in multiple sessions or maybe in joint sessions with your fertility specialist, especially prior to surgery. And you may not take only one session. This may require 3 to 4 sessions of understanding in depth and be able to make an informed choice. So I
Yeah.
think that is very important.
I agree with that. So in fertility preservation, regarding to our pocket guidelines in recent one, for like 1B, our case is at least 1B bilateral ovarian masses. So except for borderline ovarian tumors, in all other scenarios, as you can see, there is a red flag. So except BOTs, in all these, we need not to go for fertility preservation for the best outcomes in the patient. So now coming back to the patient, she underwent laparotomy, frozen section of both the masses one by one. And on both the masses, it came out to be a serious borderline tumor with invasion cannot be ruled out. So as we discussed, the role of pathologist is very important here. So Dr. Komal, can you enlighten us on the accuracy of frozen section in borderline ovarian tumors?
So, as we all know, frozen sections are highly accurate in classifying the benign conditions from the malignancies.
Yeah.
Benign in that, like endometriosis or tuberculosis or any benign epithelial neoplasm, it is highly accurate with a reported accuracy in between different series of around 90 to 97%. But when it comes to the diagnosis of a borderline tumor on frozen section, the reported accuracy in various series is between 60 to 80%. And the major reason for the decreased accuracy in settings of the borderline ovarian tumors is the first thing is the sampling error, and the second is the tumor heterogeneity, especially when it comes to the diagnosis of the mucinous tumors, since we can see the entire spectrum within one single tumor ranging from benign to borderline and
Dr.
malignant.
Komal, we are talking about borderline serous tumors.
Yeah,
So
so for borderline serous tumors, the overall accuracy is more than 93%, which is far better as compared to that for borderline mucinous and borderline endometriotic tumors.
So here the pathologists have said that the invasive malignancy cannot be ruled out. So which is a very important statement for the
Yeah.
surgeon who is standing in the OT, and it has a lot of clinical as well as the medical legal implications for the surgeon standing in the OT. I think all my gynae oncology colleagues will agree with me on that. That
Yeah,
invasive
but
malignancy cannot be ruled out means a lot to a surgeon.
the pathologist is always in a soup whenever we are dealing with a borderline tumor. If we see a frank invasion, then only we can label a tumor as a low grade serous tumor. Otherwise, the major issue with the borderline tumor is always underreporting, and it could be within the range of around 20 to 30%.
So the pathologist is medical legally safe. So now Dr. Shruti, Dr. Neha, Dr. Swasti, Dr. Renuka, it's all up to us. Okay, should we go for the fertility preservation when the frozen section of one ovarian mass is like borderline serous when invasion cannot be ruled out? Dr. Neha.
So, Dr. Manisha, like was rightly said, the counseling of the patient has to begin in the OPD, and all these scenarios should have been discussed with the patient beforehand. And also, we should be informing the relative and especially her husband what the results are during the OT.
Yeah.
So, if the patient is not keen on fertility preservation, I would go for complete staging. If, on the other hand, patient is still very, very keen on fertility preservation, I would give her a chance, remove the bigger mass, try to save a bit of the ovarian tissue, whatever normal ovarian tissue I can of the smaller mass, along with the uterus, provided it is grossly normal. If,
Okay.
on the other hand, there is no gross normal disease left, then we have to explain to the patient's relative that it is not possible and I have to go for the complete surgery. The last option, if both ovaries cannot be saved, is that if the uterus is grossly normal, that can be saved and the patient can conceive in the future with donor oocytes.
So if the patient is keen on that, so at least in
Yeah,
this case, we
if the
can
patient
preserve the uterus.
that, correct. Yes, if the patient is.
Yeah, any other opinion, Dr. Shruti, Dr. Swasti?
Yeah,
No,
I
I
agree with
think Dr. Neha summed it quite well.
Yeah, Dr. Shruti, any opinion?
Right. No, same as Neha said, I agree with her. Good prior counseling. Actually, we have to explain all the scenarios. And as patient wishes, we proceed accordingly. And yes, whatever your frozen report is, we tell the relatives and tell them with the caveat that again, frozen section is not 100% accurate. If the
Yeah.
disease is upstage in the final histopathology, then we may need to go for a second surgery if we are
Yeah.
doing any conservation.
So
Just
that
a
is
just a practical
some-
tip, Monisha.
yeah.
Whosoever is referring to you, the patient, and who's whichever physician has the maximum confidence with the patient and their family, just involve that journal practitioner and counsel as what it's in Neha's Kumar mind. So if it is a bilateral ovarian, ovarian cannot be saved. Go what Neha is saying, but take the journal practitioner or a referring physician into the mind. Patient will always listen the primary obstetrician or the primary GP or a primary community doctor, which he has
So
the highest faith.
totally practically agree with you, Dr. Ankur, but like we have to discuss the clinical aspects of the disease.
Yes.
On that,
Clinical
Dr.
aspect,
Neha,
legality, and all.
Dr.
But
Neha
yes,
is perfectly
in
right on that.
your busy OT, it's
Yeah.
not always to come out of the scrub and
Yes.
whole family standing, and you
Totally
can't make
agree.
a scene out कि बच्चा बचाएं या बच्चा होगा या नहीं होगा.
Yeah.
It's always whatever is in your mind. Go
So
with
my
that
Dr.
prejudice
Ankur, my
and
point of discussion is if one is having a report of serious borderline tumor when invasion cannot be ruled out, are as a cancer specialist, are you going to tell your patient wherever it is like
but
whatever
whenever
you are
Komal
not
gives you a
going
final
to
report,
preserve the fertility?
whenever Komal gives you a final report that suggests
Yes.
invasion, look, it's a frozen section.
Yeah.
It's a frozen
So
section
I
with half an hour with you.
pointed out we
Ah.
can, if the patient is really keen on preserving the fertility, we can plan a second surgery.
My take is
Based upon
also
your-
same
Yes,
that we can plan a second surgery.
second surgery based upon your frozen if the patient is really keen on fertility.
Yeah.
But yes, when you're getting a report of when invasion cannot be ruled out, it's very dubious to do a fertility preservation and come out with a clean hand. It's very dubious. So with that, coming back to this patient, because she was not very keen on maintaining the fertility, and as Dr. Ankur has said, I talked to my GP. She underwent a complete surgical staging with the complete removal of like both the ovaries, the uterus, omentum, nodes, and this came out to be a final histopathology, and it shows a serious borderline tumor involving both the ovaries with breaching of the capsule on both the sides, with involvement of 2 out of 21 lymph nodes with non-invasive plants on the right, similarly on the left, and the paraiotic nodes, momentum free. So basically, now coming back to my colleagues, how will you proceed? Serious borderline tumor with non-invasive implants in lymph nodes, pelvic and paraiotic. To start with, Dr. Swasti.
Yeah, you always start with me. So, so when you have a serious borderline tumor, your pathologist is saying no invasion, and you're having nodal positivity. It's very, very rare on a borderline tumor to have that. So, though it's not unknown, but it is very extremely rare. I think there's no harm having a
You know,
review.
just out of the box, I'm just saying कि I called my pathologist and say, यार
Yeah.
guts चाहिए ऐसी report देने के लिए.
So, but if
Yeah,
they're still
continue.
very confident, they're not able to see. The reason why I'm saying this is because I could see in the report that there's a capsular breach. Sometimes pathologists are also, their hands are tied in areas where there is possible some sort of micro invasion or some invasion, and that is the area of the breach of capsule. They may be able to not comment on it clearly. They may not be able to see the invasion clearly.
Yes, yes.
So the other aspect is if we have a slide review, you will be able to take more confident decisions regarding the management of a young patient.
Yeah.
Because our whole orientation with the stage 3 disease with invasive cancer will change in terms of adjuvant treatment.
Yeah.
So I think that is something first
Dr.
of our
Neha,
hand we
your
have to
take
do.
on that. Next, Dr. Neha.
Yes, I would also like to go for a second opinion, Dr. Monica, because this is a position where, this is an unusual position. Like Dr. Swasti rightly mentioned, you don't really expect a lymph node metastasis to come in a borderline tumor. I would like to get a second.
Non-invasive implants can be there. Non-invasive implants can be there, but
Hmm.
they're actually
Can be
very rare. They're
very
actually
true.
very
True,
rare.
non-invasive implants can be there, but it is always better to have a second opinion
Second
because
opinion.
you
Yeah.
need to low grade tumor, and that
Yes.
can change our plan. They can, if it is high
Change.
grade, if it is stage 3, it will change our adjuvant treatment, whether we keep the
Yeah.
patient under close surveillance or we give her adjuvant treatment. So I would definitely like to have a second opinion.
Dr. Shruti?
I agree. We should have a second
How
opinion.
often do you see such reports and borderline tumors with non-invasive implants in the lymph nodes? Because routinely what is said ki you
So,
don't need to remove the lymph nodes if your frozen is borderline.
yeah, it's a very rare finding, but somehow I have operated one such patient last year, but this was a 70-year-old plus lady. Same
Yeah.
findings. We were given a frozen section borderline, and the final was upstage. And we were skeptical because, anyways, her nodes were enlarged on imaging. So we had removed the nodes, and nodes came out to be positive.
Yeah.
So,
Yes.
otherwise, it's a very
Positive and
rare thing.
non-invasive or
Yeah.
invasive.
Non-invasive. So
Non-invasive.
I would go for a slide and block review in this case, and then also we can do a P53 marker test.
In this particular scenario, P53 is not going to be helpful to differentiate a borderline tumor from
Yeah.
low-grade serous carcinoma
I
because
agree.
both are wild type on P53 analysis. That is the
Yeah.
first thing. In the
P53
initial report, the
is
pathologist has used the word non-invasive implant. It
Hmm.
is as good as having a non-invasive implant in the omentum.
Yeah.
Whenever the pathologist uses the term invasive implant, that essentially is a low-grade serous carcinoma. So we have such tumors where in the ovary you can have a borderline tumor, and in the omentum there are invasive
No.
implants, and the final classification will be a low-grade serous carcinoma. So here I think the pathologist is justified in reporting that as a non-invasive
Yeah.
implant. We may see at times, though it is rare.
It is
Yeah.
very, the only point is it is not like observed report. No, borderline ovarian tumors with non-invasive implants can be there. But the only thing is it is a very rare pathology, and that is why it amounts to be like
Yeah,
maybe,
sure.
second
Yeah.
or third time. That is the only point. So yeah, and you are correctly said that P53 is not to differentiate between borderline or low grade. It is basically to differentiate between low grade and high grade, if I'm correct.
What could be the worst second opinion pathology in this case, Komal? I'm the odd man out here. All ladies, I'm the only
So
man.
what I understand, Dr. Ankur, the reporting pathologist has nicely written the word non-invasive implant.
Nicely written, Komal, but
Yeah.
what could be the
Yeah. So
worst second
that
opinion
the
in this?
worst could be it's a
Could be
low-grade serous carcinoma. That is the most.
Worst. Can it be a so
high
if
grade.
everybody is saying they're
I think there is
positive,
a good
non-invasive implant,
inter-observer
No,
agreement when we
one
deal
thing,
with a high-grade serous.
Dr. Ankur,
high
this
grade
report,
serous, yes.
this
Yeah.
report is after a P53 evaluation, and P53 was wild, which I have missed out to write in this. It is a P53 wild report. This report is. So there is nothing like high grade in this report, but the only thing is it is a
Missing
borderline.
on a high-grade serous
Komal, will
carcinoma.
P53 actually determine whether it is a low grade or high grade or a good histopathological
It is a
examination will?
good, the
Yes,
first essential
P53
criteria
is
is
not
the
going to.
morphology.
Yes,
And it is
yes.
extremely rare for any pathologist to miss on a high-grade serous carcinoma.
Even if it is P53 mutant, will you give it a high grade?
No, it depends
No.
first on the
Yes.
morphology. That is
Yes.
the essential
Histopathology.
criteria.
Yes,
Low
yes,
grade
yes.
can also
Rarely
be
there can be low-grade tumors in around 2 to 5% cases.
can be
Low-grade serous carcinomas can be
Absolutely.
P53
Absolutely.
mutated. Yeah.
So
so
second opinion will change on histopathology, not on P53 in this case.
Yeah.
Yeah.
So taken that point, Dr. Ankur. So second opinion we take in this case from Rajiv Gandhi, and it totally changed the table. It is like the final pathology came out to be a low-grade serous carcinoma involving both the ovaries and lymph nodes also, with the invasive implants in the lymph nodes, and also there is an invasive small focal invasive implant in the omentum also. And again, the expression 53 was negative, 80% strongly positive. So it came out to be a bilateral low-grade serous carcinoma with negative P53. So now, yeah, Dr. Komal, she has already commented that
Just one more comment.
yeah,
Differentiating non-invasive implants from the invasive ones, that is the low-grade serous carcinomas, can be very challenging.
yes,
And there is just one finding which helps us to differentiate the two, and that is the presence of desmoplastic stromal response. So whether it may be there in the lymph node, it may be there in the omentum. I may feel that it is a desmoplasia secondary to the tumor in the omentum, but the other pathologists may not agree, which has happened in this particular case, maybe. Yeah.
Okay. So, Dr. Komal, I would like to know if there is something like micro invasion also, like something.
Yeah, so any focus which
Dr.
is
Monica,
borderline and low
we
grade.
need to wrap up the case also
Yeah.
because it's already 8 o'clock and Dr. Lakshay has to leave for a meeting now. So he
So,
won't
just
be
a
available.
comment on molecular biology. I think Dr. Komal will tell you there's a lot of studies on molecular biology evaluation in low-grade serous carcinoma, and more than 50% of tumors are PK pathway mutated. And Dr. Just to last question to Dr. Ankur, and he has to take all the questions about molecular profiling in low-grade serous ovarian carcinoma, role of germline BRCA testing in these tumors, chemotherapy, hormonal therapy versus hormonal therapy only as adjuvant treatment, and any role of targeted therapy in the after setting for low grade. So, Dr. Ankur, over to you.
I'll take one by one. Molecular profiling, how important? Not that much. It could be a bookish thing and to complete the process, but yes, as such, molecular profiling or a genomic profiling or a comprehensive genomic profiling, not that important in uh, LGSC, low-grade serous carcinoma versus borderline, both of the cases. Monisha, can you go to the next slide, please? Or before that, 4 questions. I'll take one by one. All the 4 questions, yes.
Yeah.
The role of germline BRCA testing in LGSOC, it's not a high-grade serous, and it's not, if you take it node positive, which make it FIGO 3, get it done, germline BRCA 1, 2, because she's 32 bilateral ovarian carcinomas. Even if it is a low-grade serous, there's no harm in getting chemotherapy.
So, BRCA
hormone
testing is like a standard genetic testing ovarian cancer screening protocol as we do for high grade. Just for that,
yes,
or
I
other
would still suggest if the doubt between low grades, there's a component of serous here. And if even if it is a low grade nodal positive or a imentum implants, or yes or not, but if it is not borderline, get it done. I would not mind it doing it.
Yeah.
Chemotherapy, borderline, no for adjuvant chemotherapy, low grade serous. Although the chemo sensitivity is modest, it's not very chemo sensitive disease. But yes, paclitaxel carboplatin in a low grade serous carcinoma, hormonal therapy of giving letrozole or anastrozole, even if there's a habit of doing ER/PR in all the ovarian cases, there is no data, hardcore data of giving maintenance chemotherapy or maintenance hormonal therapy or any kind of AI or letrozole or tamoxifen. Not a robust data on this thing. And role of targeted therapy in upfront setting, a big no. No role in GOG or in ICON 7 or GOG 218. These disease were not taken, and there's no data of giving any bevacizumab or any other targeted therapy as per genomic profiling. So that's what I'm saying. Molecular profiling do not have much to contribute in such cases.
But last year there was a like low grade cancer, ovarian cancer awareness day. So there's a consensus that these pathways are like maybe a prognostic marker for the future trials. And patients who are like less than 35 years of age with these kind of mutations, they have a better prognosis versus those who don't have these mutations like BRAF.
Predictive and prognostic are two different things. You're asking me a predictive thing, but adding letrozole or anastrozole is not going to have a DFS or a OS benefit in such patients.
Okay, fine. So with that, we come to our end. So some take-home points for the gynecologist. It's always important to evaluate every ovarian mass with a mind that to rule out malignancy as far as possible. Clinical assessment, markers, imaging is very important. They are only suggestive, not confirmatory. Surgery is the most important diagnostic as well as curative. Biopsy, FNAC in a resectable disease should not be done. Upstage the disease. Frozen is a very important and essential part of management and should be incorporated whenever and whatever available. Laparotomy is a preferred approach, although there is a narrow role of laparoscopy in a selected group of patients. For my oncologist, Borderline tumor, fertility preservation, that is a norm, but that should be critically evaluated because according to recent data, 60% of low-grade serous cancers contain associated BOTs in the same specimen, as Dr. Komal has pointed out that it's a heterogeneous tumor. And these low-grade serous cancers are 60%, they are like in stage 2 to 4 after proper staging with a high rate of recurrence. They are characterized by overall good survival because they are low grade and the recurrences are also managed very well. BRCA mutations are very less, but still, as Dr. Ankur has said, we are going to go for a cancer genetic screening guidelines as per. We need to go for a multi-gene panel testing in these patients, and MAPA pathway may be the, like for the future, it may be there because molecular profiling is being evaluated for the low-grade tumors. Chemotherapy and plus hormonal therapy is the current conventional standard for these patients in stage 2 to 4 as adjuvant treatment, although the results from the phase 3 RCT are awaited. Thanks. So over to Dr. Vaishali for your case. Thank you.
Vishali, you have a case too.
Yeah.
Very good. Come, start.
Desktop one. Yes, yes, So my screen is visible? Is my screen visible?
Yeah, it's visible.
So I will finish my case a little fast also because we are already short of time. So she is a 32-year nulliparous female. She has been married for 2 years with the chief complaints of history of oligomenorrhea for the past 2 years. She started having urinary frequency, early satiety, bloating for the past 3 months, history of constipation on and off. Basically, she was being evaluated for infertility. She did have a pre-op MRI, which we don't have in images because this patient came to us as a second opinion. So as a part of her infertility investigations, she underwent hysteroscopic polypectomy and lab bilateral ovarian cystectomy on the basis of suspicion of an endometrioma. So in the intraoperative, there was intraop rupture was present. The pathology came out to be a low-grade serous cancer on the background of a seromucinous cyst adenoma. When the HPR was reviewed, it was a clear cell carcinoma. Only cystectomy has been done for this patient. The pre-op tumor markers all were normal except CA125 was 60. Inhibin B was slightly raised and the pre-op MRI reported that it was only a right adnexal mass with a predominantly cystic component. So the final diagnosis that we have as of now is an incompletely staged 32-year-old female with a clear cell carcinoma stage 1C1. So my question first is to Dr. Neha, like what are the actual risk factors for a clear cell cancer in this patient?
In this patient, she is nulliparous. She has history of infertility and endometriosis. So these three are risk factors in this patient. Otherwise, the well-known factors are age, BMI, raised BMI, endometriosis, like I already said, genetic factors, they may also play. But in this case specifically, it is infertility, nulliparity, and endometriosis.
Yes, and specifically in the genetic factor, clear cell and endometrioid cancers can be associated with Lynch syndrome. And East Asian population is more likely to have clear cell cancer. And contrary to cancer being the median age of ovarian cancer being 60 years, clear cell cancer can present it is more commonly found in younger age groups. So our Dr. Lakshay is actually not there. So I would just like to summarize the findings. So what I wanted to ask him is that how can we differentiate pre-operatively an endometrioma versus a clear cell tumors? Because we can have nodules in both the masses. Generally, so the endometrioma nodules, they tend to be broad-based, and the clear cell cancers, they tend to be eccentric, focal, and enhanced on contrast. So, Dr. Swasti, would you like to add anything to this in the imaging?
So we've done an MR.
MR, for MR.
Yeah. So that's okay. I think this is quite all right in terms of understanding how would we differentiate between an endometrioma and a clear cell carcinoma. Some diffusion restriction has to be there, in a malignant sort of a situation. In endometriosis, definitely you have a lot of other characters. There's not much chaos, but the background of endometriosis is definitely there in most of the younger women with clear cell carcinomas.
Yes, and that's why we get a lot of cases who
Cases,
undergo
yeah.
cystectomy for the
And
suspicion of
especially
endometriosis.
those who've been a lot on medical management for a lot of time, because somehow, we have to understand if somebody is presenting with a solid area on an MR and that solid area is progressing, so one has to stop medical management there and understand it's a possibility of cancer. So you've rightly shown on an MR on the next slide the kind of image, and the intracystic
Yeah, so
solid
these
area.
components. So basically, as we have already discussed, the morphological features of imaging actually are the most important to characterize any adnexal mass as suspicious. Papillary projections, solid enhancing masses, they
Hmm.
generally go more in favor of malignant tumors.
Right.
So, Dr. Renuka, what could we have done differently in this case?
Vishali will PET scan the activity on the PET scan because clear cell has a higher proliferative index as compared to endometrioma. So don't you think a PET scan will actually guide us in the high uptake, SUV uptake of this mass proliferating will help us in PET scan? Just a view.
So we did when she came to us, but when she was being investigated for infertility, then only this MRI was done.
Okay,
So
okay,
when she came to us, we did advise a PET scan
okay.
for the complete imaging. So Dr. Renuka, are you there?
Hello. Huh. Actually, whenever we are dealing any patient with such an MRI reports, basically, I would like to say the chances of malignancy could be there. So definitely, if I'm dealing this case, I'll do diagnostic lab. But eventually, whenever I'll feel that rupture is there or some suspicion is there, I would like to go for the open surgery. If I'll feel that yes, I can remove the mass in toto in bag completely for the frozen, I'll take it to the bag. Otherwise, usually I don't do the laparoscopic surgeries in such a big masses because definitely we cannot take out this as an intact mass. Okay, if I'll do laparoscopy, definitely I'll take into the bag and then do the mini laparotomy to remove. But if I'll do the mini laparotomy, if it is come out to be positive, then definitely I have to extend the incision and all. So usually I won't do the laparoscopic surgery for these kind of patients. I usually do the open surgeries, take out the masses and go for the frozen section for these masses. And depending on the frozen section, it is a benign, borderline or malignant, then I'll usually proceed for this patient.
So complete intact removal of the mass is important, and what
Is
we
very
have to
important.
basically avoid is a spill of any
A
kind,
spill of
because we
any
are
kind.
going to
Yes.
upstage the tumor. We are going to upstage the cancer. So
Yes.
definitely in this case, preoperative MRI did show some solid tumor which was not
Yes.
reported earlier, and therefore the surgery we could have changed it. We could have done an in-back removal of the mass.
Yes.
So Dr. Komal, div- uh, on frozen section, I think. What all differentials are there for clear cell carcinoma? Because in this patient, she's a young patient.
So she is a young patient. I would like to rule out a possibility of a sex cord stromal tumor or maybe a germ cell tumor as well. But frozen section will be accurate in classifying the clear cell carcinoma from other malignant neoplasms as well as from endometriosis.
Yes. So in this case, definitely we will have a good guidance in our surgery, because we can clearly distinguish it from endometriosis. Any cancer, even if we have any confusion between, I think, clear cell versus germ cell, we will diagnose the adenoCA that is present basically, right?
Definitely.
And Dr. Neha, is there any role of two-stage surgery, as we have already discussed, because she was a young patient, and if on pre-operative MRI we did see a solid mass, only a unilateral mass, then how would you have counseled the patient? She is nulliparous. She is 32-year-old with a solid cystic right adnexal mass?
So I think if on MRI there is such a high index of suspicion as you showed in the pictures, and it is a unilateral mass, I would err on the side of caution and remove the complete mass in toto without spillage rather than do a cystectomy, because she still has the other ovary for her fertility. And if fertility is that much of a concern, if possible, we can go for an oocyte retrieval beforehand, because if I'm correct, the other ovary was normal.
Yes,
So
the other ovary was normal.
try to do cystectomy in this case with that kind of an MRI image. I would like to remove the complete ovary.
So what I wanted to just point out is that two-stage surgery, Dr. Neha, I mean that you would only remove one ovary and then take the decision on the final histopathology for the other ovary.
Yes, in case there is a doubt and the family is not decided, yes. For a clear cell where the disease has not spread anywhere, yes, there is definitely a role of two-stage surgery, and we can remove the mass, do a complete staging, preserve the uterus and the other ovary, and come back again if need be.
Yes, so I think that again, pre-operative counseling is important, and wherever fertility is the issue, generally MRI has to be done even in conjunction with the PET-CT, so as to know the status of the uterus and the other ovary, and we can always plan a second surgery after the final histopathology report. So again, the emphasis is that we have to avoid spillage during surgery, any aspiration of cyst, cystectomy in case of a solid cystic mass, delivery of tumor through a small incision, again where the chances of rupture are high, or morcellation or piecemeal debulking should not be done because it upstages the disease and which ultimately can lead to a poorer survival rates. So now the first review of this patient was a low-grade serous cancer on a background of seromucinous tumor. Then, and when it was reviewed, it came to be a clear cell ovarian cancer. So, Dr. Komal, can you just elaborate on what are the features of clear cell, which other tumors we can
So
confuse them with?
mostly on morphology, we can, I think, easily discriminate a low-grade serous carcinoma from a clear cell carcinoma in up to 90% of the cases. Some tumors will show overlapping features on morphology, like presence of papillae in both low-grade serous as well as in clear cell carcinoma, presence of clear cells in low-grade serous carcinoma. But then the pathologists, if we are facing a challenge of having overlapping morphological features, we always have an option of doing the extended immunohistochemical panel. And on immunohistochemistry, we can easily differentiate a low-grade serous carcinoma from a clear cell carcinoma. So personally, I don't think that there should be a challenge in differentiating a low-grade serous carcinoma from a clear cell carcinomas. And studies have observed a good, concordance rate when it comes to the diagnosis of a clear cell carcinoma. Yeah, so I think IHC in the first setting only would have been helpful in arriving at the correct diagnosis.
Yes, definitely,
So
because a low-grade
as
serous.
is seen in this slide, the clear cell carcinomas, they are mostly hormone receptor negative. They are P53 wild type. Only one-third cases may be P53 mutated clear cell carcinomas. And clear cell carcinomas, they have this peculiar expression of HNF1 beta and napsin and amarker. Since they arise in a background of endometriosis, they can also show a loss of ARID1A, which is an immunohistochemical marker. On the other hand, low-grade serous are mostly hormone receptor positive. They again are P53 wild type. So again, P53 may not be helpful in differentiating the two tumors, but the low-grade serous tumors, they are WT1 positive, whereas the clear cell carcinomas are WT1 negative. So a good panel of IHCs will be helpful in differentiating the two tumors, I think, accurately.
So IHC markers are very important because in this patients, a low-grade serous versus a clear cell ovarian cancer, it is a big difference for a clinician because fertility preservation is indicated in a low grade serous cancer, but a clear cell ovarian cancer is by definition a high grade cancer. So the management changes, and here the importance of a pathology review and IHC staining comes. So it's always a good idea to get a slight review from expert pathologists, particularly from young patients, as fertility sparing surgeries have to be planned in these patients. So Dr. Ankur, as this patient came to us after this HPR review, we did do a PET CT. In the PET CT, there was a soft tissue lesion on the right side where the right ovarian cystectomy was done. So probably the part of the ovary was removed as the cyst, and the remaining solid area that was stuck to the uterus that was left behind, was suggestive of a mitotic pathology. SUV was around 9.9, but there was no disease elsewhere. So, Dr. Shruti, what would be the further plan for this patient now? The patient has come to you after a cystectomy. The PET CT is showing localized disease in the right adnexa.
So, as you have rightly said, clear cell carcinoma are not good tumors. They are a high grade tumors by themselves. In fact, they are known to be in a very early stage. They can behave like a good tumors, but the moment the stage is 1C or beyond, they are very bad tumors and not very chemo responsive. And moreover, a lot of occult metastasis has been seen even in early stage. And this patient has just had a cystectomy with a very high recurrence rate now. So looking at her fertility problem and the disease, we have to do a good counseling. We can discuss the case in our tumor board, and then ideally I would go for a complete staging surgery with the caveat, and because the PET CT does not show a disease all around it, just a localized disease, we can think of fertility sparing surgery, but it has its own complications. And for that, I would say instead of doing a fertility sparing, we can do a oocyte retrieval and remove the ovaries and remove both the ovaries and do a complete staging.
Yes, I think that would be the plan. I think involvement of a fertility specialist would be important in this case. The importance of MDT and oocyte retrieval embryo cryopreservation is feasible as she is married, and then we can proceed with a complete staging surgery. So, in complete staging surgery, would you preserve the uterus or you would not?
No, we can preserve the uterus. She's a young lady, and for ovarian cancer, we can do that.
So yes, that can be explained to the patient. Although again, she has to be explained the possibility there is a remote chance of recurrence even in the uterus.
That's true. That's true. A good counseling is actually very important. In this case, we involve the fertility specialist and do discuss it with the patient and the attendants.
So Dr. Neha, is there, because the cyst was ruptured, there was spill. Do you think there is any role of heated intraperitoneal chemotherapy during the surgery in this patient?
So it's a very
Suppose you
tricky.
go inside, you find some peritoneal disease here and there also, although this patient did not have it.
Yeah,
So you find a nodule on the diaphragm that
correct.
makes it maybe stage 3
Yeah.
also. So
Okay.
would you do HIPEC in this patient? Would you counsel the patient for HIPEC or no?
Okay, so full disclosure, you're asking this question to someone who is pro HIPEC. So now the thing is, we will not get any evidence for clear cell carcinomas which have been ruptured intraoperatively by gynecologists, because clear cell carcinomas by itself is not a very common histology. And ruptured clear cell carcinomas in the presence of pneumoperitoneum is an even smaller subset. So we don't, the answer to your question is we don't have any evidence that there is any role of HIPEC in this subset. But outside the setting of a clinical trial, it can be considered. That would be my answer to you.
Yes, because sometimes the patients also ask whether
Yes.
HIPEC is required.
Because
So
the tumor has been potentially exposed to the entire peritoneal cavity in the presence of pneumoperitoneum under high pressure. So while we don't have evidence for it, neither will we get evidence for such a small subset. This is something which can be considered outside the setting of a clinical trial.
So, a complete staging surgery in which we either plus minus uterus, both the ovaries we are removing, bilateral pelvic lymph node, retroperitoneal lymph node, omentectomy, and plus minus HIPEC, because there is a small subset of people who are pro for HIPEC in patients who have ruptured tumors and they present after some time. Okay, so these
Yeah,
are
but
just,
Dr. Vaishali, upfront HIPEC in a primary setting is still, as Dr. Neha
there
said,
is no
in clinical
evidence. Yeah,
trials. Yeah,
that is right, ma'am. There is
there is
no
no
evidence.
evidence.
Yeah.
It's
So
just that because it has been exposed under very high pressure under pneumoperitoneum, clear cell carcinoma by itself is not very responsive to IV chemotherapy. So we don't have evidence, neither will we get evidence for such a small subset. But it is something which we can consider outside a clinical trial.
Yeah.
And in the future, with OV HIPEC, being done OV HIPEC 2 for coming, primary setting, we now get evidence for HIPEC even in a primary setting later on.
So comprehensive staging is very important, and it is basically these early tumors in which actually gynae oncologists can make a difference in the survival of the patients. And almost 30% patients can be upstaged with comprehensive early staging of early ovarian cancer. So of course, with proper staging, the survival of the patient increases. So this patient underwent a TH, PSO, because both the ovaries were stuck to the uterus, the fallopian tubes were also stuck, a bilateral pelvic lymph node, retroperitoneal lymph node, ometectomy, pelvic peritonectomy. So now the question is, the final HPR has come to be uh, only the right ovary has been involved. Rest everything was negative. So it technically becomes 1C3 because the surface deposits were also present over the ovarian surface. So, Dr. Ankur, what would be the adjuvant treatment for these patients? And would you
Say,
like to do any additional marker to include maybe
eh,
immunotherapy?
yes. So coming on to clear cell carcinoma, 1A observation or maybe something, because as previous panelists say, they are not as sensitive as high grade serous, but very aggressive ones, difficult ones rather. 1C, there is a clear evidence that we should give 4 to 6 cycles of paclitaxel and carboplatin. In second line, we say clear cell irinotecan is more the drug in second line, but yes, first line paclicarbo. In clear cell, whatever I have practiced, yes, the mutation burden is quite high in clear cell, PIK3, AKT pathway, mTOR pathway, ARDI1. These are the some mutations, but as such, we do not have an evidence of giving any upfront immunotherapy in an adjuvant setting in ovarian carcinoma. Yes, in a recurrent setting, the data is coming up. And regarding the previous HIPEC question, few of our patients also land up to medical oncologists, but yes, a HIPEC looks reasonable, justified, but still unproven in clear cell. So I would suggest that we'll go with standard paclitaxel and carboplatin 4 to 6 in 1C when there's a capsule rupture, spillage, or a peritoneal pelvic implants. Same paclitaxel and carboplatin.
Okay, so in the recurrent setting, we will be doing maybe additional markers
We
because
will be doing
sometimes they can have association.
additional marker and
MMR.
MMR, MSI, even now there's a data of PDL1, HER2 new low. But yes, in second line clear cell, we all oncologists prefer irinotecan based therapy in a second line, which has high like activity in clear cell as compared to the standard gemcitabine, lipodox, or topotecan, endoxan, or any other cytotoxics. Irinotecan is a standard second line, but first line remains paclitaxel and carboplatin as of choice.
Do you combine it with cisplatin, Dr. Ankur, irinotecan, or do you prefer to give it as
Yes. So it depends upon Neha, it depends upon the platinum sensitivity, the same criteria, although in clear cell it does not hold that a high grade serous 3-month carboplatin sensitivity. But yes, we medical oncologists always believe that whenever cisplatin can be given in any malignancy, it is far better. But yes, cisplatin and carboplatin were non-inferior when it came to the survival in high-grade serous. But cisplatin irinotecan, if patient is fit enough in a second line, yes. Cisplatin, we always say that मौके पे चौका मारना चाहिए. Cisplatin is always better than carboplatin in terms of cytotoxicity in ovarian malignancies.
So I think the basically Dr. Neha has left already. So traditionally the role of there was also a role of radiation, though in modern medicine there is not. But I think clear cell cancers and dysgerminomas are supposed to be radiosensitive. So maybe in the recurrent setting and the palliative setting, we still have a role of radiation in ovarian cancer. But otherwise, as of now, only surgery and chemotherapy form the main stay of treatment. Dr. Ankur, would you like to add something?
So, role of radiation in ovarian carcinoma, yes. People say it's an old thought, but uh, in a nodal positivity, when there are concept called as extracapsular, only a para-aortic lymph node dissection can be difficult, or a residual one. Still, I would say 3 or 4 patients in a year, we advocate radiation. But as you rightly said, it's an old concept. In presence of newer drugs, targeted therapies, immunotherapies, in recurrent setting, it can be considered in 1 or 2 patients, but not as a routine in a para-aortic lymph node recurrent setting.
I think it can be considered in Ali, I'm here. So, yeah, the subtype which is sensitive is endometrioid and clear cell because they are known to have pelvic recurrences, especially in a recurrent setting where there is an isolated recurrence in the pelvis. We can, and the patient has had recurrences. In order to increase the platinum-free interval, sometimes we can give to isolated pelvic recurrences in endometrioid and clear cell variety. And like Dr. Ankur rightly said, for isolated para-aortic lymph node recurrences, again, this is some areas where we can target with radiation.
So, Dr. Neha, we had another Dr. Neha, who is our radiation
Neha Kakkad has left.
oncologist. So she left. Okay, so I think with this we come to the end of our panel, and the take-home message is that we in masters again we have to evaluate properly. The imaging of choice for an XL masters is MRI. Solid masters, enhancing masters, they should be dealt carefully. Complete in-bag removal, and we have to avoid spill. We have to do a comprehensive staging. Slide review is important in young females, and fertility conserving surgery is possible, but in a select few. So I think with this, I thank all the panelists for joining us. I think we overshot the time a lot. So thank you for everyone's patience, and thank you to all the listeners also. So Ada, I hand over to you.
Yes, ma'am.
Can you stop my share because I'm not able to?
Okay, I'm just doing. Yes, ma'am. I'm not able to. I think, ma'am, you have to do it by your own. Okay, it's done. Okay, perfect. So as we come to the end of this enriching panel discussion on ovarian cancers, what a gynecologist must know, I'd like to extend my heartfelt gratitude to all our esteemed chairpersons and the moderators and the panelists for sharing their valuable insights and clinical experience and expert perspective with us today. So we also thank our uh, panelists for contributing their expertise and making this session academically enriching for everyone attending today. So, on behalf of IJCP Group, thank you to everyone who joined us for this session and made it to successful. So, stay connected with IJCP for more many insightful academic discussions and medical education initiatives. Thank you once again. Have a wonderful evening and stay safe, ma'am. Thank you, everyone.
Thank you.